Hello, everyone. My name is Skyline Nash. I'm the fire chief of the Lexington Fire Department. Today, we're going to be going over the life support program for law enforcement officers, fire department members, and emergency medical service members. Let's go ahead and just jump right in. So, just to let you know, this slideshow is fully editable. So, if you do get a copy of this slideshow in my department, it can be edited and can be revised at any time. So, why should you join Lexington Fire Department's Basic and Advanced Life Support Program? So, the Basic Life Support Program is aimed towards law enforcement officers and Lexington Fire Department members alike. This program will serve as a recognition of your achievement. This course is also aimed towards everyone who wants realistic and quality roleplay experience within the Kentucky State roleplay community. We also have amazing perks for the reason you should join us as well. So, career development, so basic knowledge and career growth, eligible for department member giveaways, program flexibility and official certification. So, you got no quota requirement doing this. You work at your own pace, and you get your very own certification role and official LFD certification, an expert team, and life saving skills for the basic life saving program and eligible and professional team. So, part one, basics of EMS, emergency medical responder. So this is going to be the course overview. So just to let y'all know, this course is not a one and done course. There will be multiple and advanced courses within to gain real life knowledge to properly save a life. Please note, this course has the capabilities to actually save a life, but is not an official or lawful certification course for a job, etc. Most of this course is classroom based, just how we are video based. We'll be going over 7 sections today. We'll be talking about the course introduction and objectives, primary assessment and why it's important, high quality CPR in adults, airway management and ventilation, automated external defibrillator or AED, special resuscitation situations, and medical emergencies. All right, let's just jump in. So, Section 1, Course Introduction and Objectives. So, purpose of basic life support, importance of early recognition and intervention, scene safety, and personal protective equipment, or PPE. So, basic life support, BLS. So, it's maintaining life through immediate recognition and intervention in life-threatening emergencies. The definition is just as explained, but it's immediate recognition of life-threatening emergencies, and it's about early and effective intervention to maintain life. Some core training objectives. So we're going to learn some. We won't be doing the physical skills, but we'll be doing demonstrating high-quality CPR and operating an AED correctly during this course. Some procedural knowledge. You'll understand the purpose of basic life support, manage airway and breathing, and provide care until advanced help arrives. So understanding the importance. So the primary purposes of basic life support. Life support's physiology is maintaining oxygenation or SpO2 and providing early defibrillation. Basic physiological functions such as maintaining circulation through our ABCs or CAB. Support airway and breathing with our CAB or ABCs. Transition to advanced care, so prevent deterioration before advanced care arrives. Advanced care is described as advanced life support or ALS. Chain of survival. This is modeled after the guidelines of the American Heart Association. So early recognition and of EMS. So assess responsiveness and call for help immediately. Early CPR. Start high quality compressions with proper rate and depth. Rapid defibrillation. So use AED as soon as available and follow the prompts on the AED. Effective advanced life support, or ALS, is expert care by paramedics in advanced airway and medications, and integrated post-cardiac arrest care to stabilize and recover in critical care environments. So scene safety, the biggest thing. So ensure your scene is safe when you respond to a call. When you're on scene, double check your scene is safe. Use appropriate personal protective equipment such as putting on gloves, mask, goggles, anything of that sort. Determine a mechanism of injury or nature of illness, which we'll talk about later, and then check responses using our AFU scale, so alert, verbal, pain, or unresponsive. Remember, you can't help anyone if you become the patient yourself, so it's important that you always check that your scene is safe. Section 2, primary assessment. Before patient contact, check your airway, breathing, and circulation. So circulation, so check pulse no more than 10 seconds apart. Begin compressions if no pulse or pulse is less than 5 beats per minute. Airway, so open the airway using our head tilt, chin lift, or jaw thrust maneuver. Breathing, so look, listen, and feel, and then provide rescue breaths if needed. High quality CPR in adults, so essential standards for adult basic life support. So the compression rate is 100 to 120 beats per minute. You got to have a full recoil, so ensure chest fully rises between compressions. Airway management, so ensure that head tilt, chin lift, or jaw thrust maneuver. Compression depth of at least 2 inches. Minimize interruption, so pauses under 10 seconds doing CPR, and your ratio is 30-2 compression to ventilation ratio. So, like I said, compression rate, it's going to be that 100 120 a minute. Compression depth, at least 2 inches. Full recoil, chest must fully rise between compressions. Minimize interruption, so pauses under 10 seconds, and at 32-2 compression to ventilation ratio. Minimizing interruptions in CPR. Prioritize continuous compressions and coordinate interventions. So high quality compression, so the priority focus is switch compressors every 2 minutes using a quick transition. Keep pauses under 10 seconds and continue priority. Limit pulse checks to under 10 seconds, again, for a fast assessment. Coordinate airway and AED and using that sync team effort, so having more than one person do something. And then resume after shocks with corrective immediate action. Section 4, airway management and ventilation. Opening the airway. Head tilt chin lift, it's for indication for patients without suspected spinal injury. So if they don't have any noticeable or suspected spinal injury, this is what we'll do. We'll use the head tilt chin lift. The technique is to tilt the forehead back and lift the chin upwards. The jaw thrust is indication is for suspected head, neck, or spinal trauma. We will do jaw thrust for people in accidents, such as MVA, or just anything that could be like a fall or anything like that. We'll use a jaw thrust. So critical considerations are used to relieve airway obstructions from the tongue, ensure visible chest rise during ventilations when opening the airway and doing CPR, and reassess airway continuously. So checking to make sure it's not clogged, make sure they're breathing still, and any of that sorts. There's some airway management techniques. So some basic airway adjuncts are the oropharyngeal airway. It maintains airway patency, prevents tongue obstruction, and for unconscious patients only. So people who are not coming in or out of consciousness. They will be fully out. Oro stands for mouth. So oropharyngeal airway is a mouth air junct. A nasal pharyngeal airway, or naso, meaning the nose, is a flexible tube inserted through the nose and maintains open airway and for partial obstruction and reduced consciousness. So people are coming out of unconsciousness or, maybe have a suspected gag reflex, we could use one of these. Some ventilation methods are the pocket mask, mainly uncommon. It's a small portable device and delivers rescue breaths, and it's less preferred in EMS. The bag valve mask, which is the most common, or BVM, is a self-inflating bag, valve, and face mask. It's manually held and squeezed in primary emergency method when delivering air. So the airway management techniques breakdown. So the oropharyngeal airway, like I said, maintains airway patency, prevents tongue obstruction, and its indications for unconscious patients only. So you'll put this part right here down, and it'll go kind of sit back here. That way it's right down into your larynx. And then your nasopharyngeal airway, so it maintains open airway, used in semi-conscious patients. And the indication is reduced consciousness or partial obstruction. It'll go through the nose and sit to the back. The airway management techniques breakdown continues. So a pocket mask, also known as a CPR mask, is a small portable device used to safely deliver rescue breaths during cardiac arrest or respiratory arrest. A bag valve mask, or BVM, is a self-inflating device used in emergency medical situations to provide ventilation to patients who are not breathing normally. It consists of a bag, a non-rebreathing valve, and a face mask, which is manually held against the patient's face. The bag is squeezed to deliver air into the patient's lung, allowing for effective respiration until more advanced airway management can be performed. Like I said, here's the pocket mask. It's used to safely deliver rescue breaths. It's small and portable, so you can put it in your pocket. And yeah, and it's just an image right there, so you can take a look. So it'll look something like that as your pocket mask. Some other airways, so you got your pocket mask, has that barrier protection, small and portable again, simple technique, so no assembly. You got your bag valve mask, which is positive pressure ventilations for apneic patients, so people who aren't breathing. That's what apneic stands for. Oxygen supplementable, so you can attach it to a 15 liters per minute oxygen rate, and manual operation, so a rate and volume control. Pharyngeal airway adjuncts is the tip of the MPA should sit at the opening of the oropharynx. See how there's the the naso, sorry. It'll go right down here and into the back where the trachea is. OPA is for unconscious and no gag reflex, and MPA is for semi-conscious or conscious intact gag reflex. So some key takeaways for an OPA insertion. So indications for use. So used for unconscious patients only. Unresponsive, no gag reflex. Purpose and function is to relieve or prevent tongue obstruction. Contraindications include gag reflex, conscious patient, or active vomiting. So if you see any of these signs right here, we're not going to do an OPA. Sizing of the OPA is from the corner of mouth to angle of jaw. Insertion, so opening the airway and then insert upside down, then rotating 180 degrees as it advances, or use a tongue depressor and insert directly. Some safety considerations, so it does not protect from aspiration, and reassesses continually and remove immediately if gagging occurs. Big one. Pocket mask ventilation, so it has that barrier protection, so it provides rescue breaths with a physical barrier. Indications for apneic or inadequately breathing patients. Some oxygen attachment, it can be attached to oxygen. Avoid excessive ventilations, that's a big one, and reassess airway and breathing continuously. So open the airway using the head tilt chin lift or jaw thrust technique. Create a tight mask seal over nose and mouth. Deliver slow controlled breaths every 1 second, and then ensure visible chest rise with each breath. For an adult, it's 1 breath every 5 to 6 seconds, and for a child or infant, it's 1 breath every 3 to 5 seconds. Bag valve mask ventilation, so functional purpose and guidelines. It's for positive pressure ventilation, apneic or inadequately breathing patients. Like I said, can attach the oxygen for 15 liters a minute of oxygen flow. Avoid excessive ventilation and reassesses continuously using the airway chest rising O2. Technique and delivery, so you'll do the sealing technique, so you'll use the EC clamp grip. A two-person technique is preferred and ensure visible chest rise between breaths. And it's the same thing as the pocket mask, using 1 breath every 5 to 6 seconds for adults and 1 breath every 3 to 5 seconds for a child or infant. Avoiding over ventilation. So the functional guidelines of best practices. So deliver slow, controlled breath at 1 second each. Ventilate only until visible chest rise. Do not force air into lungs. We're focusing on quality of the air that we're pushing in versus the quantity that we're giving. Optimal ventilation rate, so it's adults are 1 breath every 5 to 6 seconds, and that 1 breath every 3 to 5 seconds. The critical risk for excessive ventilations is gastric inflation, vomiting or aspiration, decreased cardiac output, or reduced oxygenation. Oxygen use basics. So administer for hypoxia or respiratory distress. So people who aren't breathing very well are turning blue. Use the lowest concentrate needed to maintain adequate oxygenation. Monitors SpO2 levels when available. Target SpO2 range is greater than or equal to 94%, and unless otherwise directed. Continuously reassess respiratory effort and mental status. And some common delivery devices are nasal cannula, which delivers oxygen at 1 to 6 liters per minute. And those go through the nose. The non-rebreather mask, which goes from 10 to 15 liters a minute. And then you have your bag valve mask, which is 15 liters a minute with a reservoir. Automated external defibrillator, AED. So critical AED overview. Early defibrillation is vital. It greatly increases survival rates, ensuring scene and patient safety, integrate seamlessly with BSI and PPE. Continuously reassess rhythm and pulse during shocks. Key components and steps is the AED unit. It's a simple voice instruction. Defibrillator pad, so correct placement is crucial. Shock and analyze, so clear the patient completely when shocked. Proper AED use consists of powering it on, so pushing the button immediately. Attach the pads, so apply to bare chest correctly. If there's any hair, you have to shave it, otherwise it will not attach. Follow voice prompts, so listen to LFD instruction on our AEDs on our vehicles. If you're law enforcement, you'll have your own voice instructions. Clear before shock, ensure no one is touching patient. Resume CPR and then continue compressions immediately after shock is given. And early defibrillation greatly increases survival rates. Some safety considerations, so ensure no one is touching the patient during analysis or shock. Loudly state clear and visually confirm. Dry chest if wet or sweaty. Remove medication patches and then wipe the area. Do not place pads over implanted devices such as a pacemaker, ICD. This is because a pacemaker and ICD are electrical devices, and if we shock it, it'll stop that, which will kill the person. Remove excessive chest hair if needed for pad adhesion. Move patient away from standing water or conductive surfaces, and resume CPR immediately after shock. Some special resuscitation situations, so mapping key resuscitation context, so opioid overdose and naloxone. So some signs are slow breathing, pinpoint pupils, and the actions provide ventilation through BVM, and interventions such as administering naloxone or Narcan. Trauma patient resuscitation is the assessment, so scene safety with the mechanism of injury. Airway, which is open the edge with a jaw thrust maneuver, and the action is to control bleeding immediately during a trauma scene. Opioid overdoses and naloxone awareness. So signs of overdose, slow or absent breathing, pinpoint pupils, so they kind of look like the end of a pencil, like a number 2 pencil. Unresponsive or unconscious, cyanosis, so cyan meaning blue, so it's a bluing of the lips or nails. Immediate actions is to activate EMS, open airway, provide ventilations with a BVM or pocket mask, and use AED if indicated. Naloxone or Narcan is to reverse opioid effects, administer per protocol, and may repeat if no response, and it's monitored for improved breathing. So ensure the scene is safe for responders, assess response and look for breathing. If no pulse, start standard cardiac arrest protocol, so CPR and AED. And high suspicion of opioid is signs of a pinpoint pupils, slow or absent breathing. Administer naloxone or Narcan via nasal atomizer, right here on this diagram. Prioritize ventilations, BVM. Do not delay CPR for naloxone. If no response after 2 to 3 minutes, repeat naloxone administration. Continue supportive care and airway management, and continued standard resuscitative measures if needed. So for trauma patients, it's our scene safety. Trauma is mechanism of injury. Medical is nature of illness. So for a trauma patient, the mechanism of injury may be stabbing, pain, shooting pain, a lot of other types of pain. So during trauma patients, you're going to assess for this, make sure the scene is safe. Using our mechanism of injury, you're going to identify that. Spinal stabilization, so manual spinal stabilization if suspected using a C-collar or backboard. Airway management, such as airways through the jaw thrust, and avoid head tilt because it's if you do the head tilt, you can damage the neck area, especially if they have any damage to spinal. And then bleeding control, so control severe bleeding, which is your immediate action. Assess for your airway obstruction, breathing difficulty, and any signs of shock, and provide oxygen and ventilatory support as needed. Medical emergencies. So medical emergencies could be altered mental status or AMS, seizure management, poisoning and overdose awareness, and naloxone administration. Altered mental status or AMS. Understanding altered mental status. So any change from normal level of consciousness may range from confusion to unresponsiveness, and then provide oxygen as needed. Activate EMS for unexplained AMS. Some common causes of AMS is hypoxia, meaning they're not getting enough oxygen to the brain. Hypoglycemia, which means low blood sugar, so they're not having enough blood or sugar. And then stroke patients, drug or alcohol use, head injury, or seizures. Assessment step is to check responsiveness using our AFPU scale, assess airway, breathing, and circulation, and then check blood glucose levels if available. Seizure management, so protective actions. So you're going to protect patient from injury, move objects away, cushion the head, and loosen restrictive clothing. Actions to avoid is do not restrain movements and do not place anything in the mouth. Post-seizure and escalation. So after the seizure, you're going to open the airway, check breathing, placing recovery position. Activate EMS if seizure lasts more than 5 minutes. It's a repeated seizures, first-time seizure, injury, or breathing problems may occur. Poisoning and overdose awareness. So some immediate actions is to ensure the scene is safety, remove from source if safe, activate EMS, support airway and breathing. Actions to avoid is do not induce vomiting, exposure info and contact. So exposure to toxic substances, whether it's ingested, inhaled, absorbed, or injected, may be accidental or intentional. Contact poison control at 1-800-222-1222. Common signs is altered mental status, abnormal breathing, vomiting, burns around the mouth, and unusual odors. So naloxone administration, so usage and indications. So it's used for suspected opioid overdose, as we talked before. Indicated for unresponsive patient with slow or absent breathing. May repeat dose if no response after 2 to 3 minutes after administering. Continue ventilations and monitor. Patient may awaken confused or agitated, and then activate EMS, open the airway, provide ventilation, and administer naloxone through the intranasal, which is your most common technique. So it's insert into the nostril plus the plunger firmly, and no assembly required because it's already a preloaded device. And that's where we're going to leave off. Part 2, we'll see you in EMT. You guys have a wonderful rest of your day, and I hope this helps. Contact an instructor for your exam. Have a great day.